Good morning, Amravati. And at the outset, I would like to congratulate Amravati Obs Gynaec Society for this wonderful conference and this wonderful workshop, especially the fetal medicine one. It's really the need of the hour. My topic for today is timing of third trimester scan for optimizing fetal outcome. The previous speaker, Dr. Sachin, has actually covered a little bit of what I'm going to talk about. So we take it from there. The third trimester scan is actually known as a welfare scan, and it is also known as a growth scan. So essentially what we are trying to see in the third trimester scan is the growth pattern. The diagnostic ultrasound is used selectively in late pregnancy where there are specific clinical indications. When you have a high-risk pregnancy, when you have a SGA fetus, when you are a FGR fetus, it is in those pregnancies that we do this third trimester welfare scan to see the growth. However, the value of routine late pregnancy ultrasound screening in unselected population is controversial. So we as obstetricians, we have to take the call in which patients we have to do the third trimester scan. The rationale for such screening would be the detection of clinical condition which places the fetus or the mother at high risk, which would not necessarily have been detected by other means of clinical examination and subsequent management, which would improve the perinatal outcome. So if we are going to do a third trimester scan, we must do a scan because it will increase, like he said, it will increase either the maternal outcome or it will improve the fetal outcome, and not that just as a replacement of the clinical evaluation. The other side of the coin is that doing a routine scan in third trimester increases a small rate of cesarean sections. We must keep that in mind. And what are the components of the third trimester ultrasound? Of course, I won't go into detail. These are just the points: the clinical activity, the cardiac activity, the fetal size, especially the biometry and examination of the fetal weight. Very, very important. All of us would like to know what the fetal weight will be, the fetal presentation, lie. Not to miss the fetal anatomy. There are some anomalies that could have got missed in the second and the third trimester, which can be picked up later on. The placental localization, amniotic fluid assessment, and the evaluation of adnexae. These are the components of the third trimester ultrasound. Remember, third trimester scanning cannot be used for pregnancy dating, and it should not be performed because there is an inaccuracy of ultrasound in the window of plus minus 3 weeks. There is always a plus minus 3 weeks if you are going to date. Well, if a patient does not have a first and a second trimester scan, then we might have to consider the third trimester scan. The third trimester scan is aimed primarily at assessing the growth and the amniotic volume. Doppler measurements can be added in the uterine, umbilical, and the fetal MCA. It can also be used to reassess the fetal anatomy, the same systemic way as in the second trimester, but it was accepted depending on the fetal position. There could be some problems. We cannot evaluate things like fetal face and extremities in the third trimester as well as we can do in the second trimester. All cases of suspected fetal abnormality have to be examined by a specialist, and then we may even have to refer them to a fetal cardiologist if we suspect any anomalies. Now, there are a lot of indications of third trimester ultrasound. I'm not going into detail. Each one of them is a high-risk mother and a high-risk baby. So in all these cases, we need to do a third trimester scan. Now, what does evidence say? The Cochrane data says this is a review of 7 studies. It shows no difference in obstetric, antenatal, as well as the neonatal intervention between women undergoing late ultrasound examination after 24 weeks and those who did not. So in addition, there was no difference in the perinatal outcome measures such as admission to NICU, birth weight less than 10 percentile, and a perinatal mortality. So Cochrane gives a lot of importance to clinical evaluation of the patient. We have to evaluate the patient clinically and decide which babies are growing and which babies are not growing before we refer them to a third trimester ultrasound. Now, this is an interesting paper I found in BJOJ debate, that is routine third trimester ultrasound in low-risk pregnancy confers no benefit. This has been published on 20th May 2016. So they are still debating whether a routine third trimester scan is really cost benefit ratio, whether there is there, and these babies, are we able to evaluate them better. Now, policies for routine third trimester ultrasound examinations differ among the various countries. In Canada, a routine third trimester ultrasound scan is not offered to low-risk pregnancies UK offers only 2 scans the first trimester and the anomaly scan for all normal patients. To assess the effect of routine third trimester ultrasound on perinatal outcome, the interventions prompted by this abnormal diagnostic tool must be considered. If we, like he said, if we do a third trimester scanning at say around 35 weeks, 36 weeks, we must know how to interpret it, whether this baby really needs to be delivered or whether we can wait for 1 or 2 weeks. So the various indications for routine versus a third trimester indicated ultrasound is obesity in the mother, where we cannot detect by clinical evaluation whether the pregnancy is growing properly or not, whether if there is a suspected growth lag in PIH patients, in diabetic mothers, overdates, oligohydramnios and placenta previa. Now Lancet in 2015 came out with a paper of screening of fetal growth restriction and universal third trimester ultrasonography in nulliparous women. This is called as a POP study, that is a pregnancy outcome prediction study in 2015, and this was how the evaluation was, wherein they said that a routine third trimester ultrasound in a patient who does not have any other high risk really does not have much benefit. But the other side of the coin, in October 9, 2019, a late third trimester ultrasound may detect missed fetal anomalies. This came in ultrasound in OBS and Gynaec, and they said that most of the fetal anomalies, as much as 68%, which we see at 35 to 37 weeks, have already been diagnosed in the first and second trimester, and the incidence of anomalies which are first seen in the third trimester scan was 0.5%. So if we do not want to miss this small percent, we will have to do a scan at the third trimester. The study highlights the benefit of a late third trimester scan for detecting fetal abnormalities that were either mesorenal abnormalities, cardiac abnormalities, GI abnormalities. These are the main abnormalities that are detected in the third trimester. Now there is something called as a limited ultrasound examination that we do in the third trimester. We just see the fetal weight or we just see the AFI. Limited may be needed when a specific question requires investigation. Examples include evaluation of the growth or the estimation of the amniotic fluid volume. Clinically, we feel that the amniotic fluid is less, then we can do a limited scan for the AFI. Now, many people do a limited scan for the AFI, but they don't, it's not one scan, they repeat it after 2 weeks, or they go on repeatedly doing it. So this is a paper which refers to the reference range of amniotic fluid index in the late trimester of pregnancy. What should be the optimal interval between two ultrasound examination? So we should not be too early. If we do it every week, maybe it will be too early and it will not help us, and then we should not be late either. So what should be the optimal time between the two ultrasound examination? Now the third trimester can be divided into 3 parts. I have divided into 3 parts. 28 weeks, where we necessarily scan the SGA fetus, the LGA fetus. Often this third trimester scan is combined with Doppler biophysical profile. The Doppler studies are good in the surveillance of SGA fetus of any etiology, but they are of no benefit for observation of the LGA fetus. During pregnancy complicated by diabetes, the results of fetal surveillance testing will correlate with the degree of the maternal glycemic control. So these are about the scans special indications which we use at about 28 weeks. What does WHO tell us? WHO recommendation is that routine Doppler ultrasound is not recommended for all pregnant women to improve the maternal and perinatal outcome. An ultrasound scan after 28 weeks, that is a late ultrasound, is not recommended for those patients who have already had the previous 2 scans and the growth is absolutely normal and you are not suspecting anything, then it offers no value. However, stakeholders should consider offering late ultrasound scan to pregnant women who have not had an earlier ultrasound scan, which could even mean identifying fetus, placental and localization and the presentation. Biophysical profile, I'm not going to go into detail about this, often done along with the third trimester scan. It's very much a part of assessing the physiology of the fetus, how this fetus is going to perform for the next 4, 6, 8 weeks that it is going to remain inside the uterus. Then we come to the 32 to 34 weeks. They have said an average of 4.5 scans are added up in the third trimester to those patients who are from the high risk population. A 1 scan policy usually at 32 weeks or 2 scans, that is 28 and 34 weeks, results in a detection rate of about 30% FGR. Especially the late onset FGRs could be detected in this third trimester scan. Now coming to 35 to 37 weeks, abdominal circumference and estimated fetal weight perform similar in predicting smallness for gestational age. However, for a fixed 10% false positive, the rate, extrapolated sensitivity is higher for the abdominal circumference. So abdominal circumference might be specially little bit better predictor of the fetal weight when compared to the other parameters. There is evidence of better performance when the scan is performed near term, like near term 35 to 37 weeks, and the fetal growth restriction is in the targeted condition. So when we want to estimate the fetal birth weight, and we have to evaluate the abdominal circumference, and it is better done near term. At 35 to 37 weeks, prediction of subsequent development of preeclampsia and delivery of small or large for gestational age neonate. Additional benefit of such ultrasound is detection of previously undiagnosed anomalies because it could have been missed in the previous scans. Short limbs like in achondroplasia, dilated bowel in bowel atresia, abnormal shape of the head in craniosynostosis, or third, abnormality develops which only during the third trimester, associated ovarian cyst and ventriculomegaly, hemorrhage, maternal infection. These could be the other indication for the assessment at 35 to 37 weeks. Now what happens in diabetic patients? These are a very special group of patients. In these patients, ultrasound between 34 to 36 weeks better predicted the birth weight as compared to an earlier ultrasound if we did it between 31 to 36 weeks. So if everything is going well for the diabetic patient, an ultrasound between 34 to 36 weeks definitely correlates with the birth weight. If there is obesity in the mother, late ultrasound always correlated better with the fetal weight. So in short, a third trimester scan there is nothing like a screening third trimester scan which we do for all the antenatal patients, but if there are any high risk mothers or high risk fetuses, then a third trimester scan surely has got a value. When you have a certain question in mind, it definitely gives an answer for the scan. Therefore, we have to be very, very selective in which population we do this third trimester scan to enable us to give optimal fetal outcome. Thank you.